Good morning and welcome to my YouTube channel, Pain Free Partha. Today's topic is about failed spinal anesthesia. Now, welcome to Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapeeth, Pondicherry, and our Professor, Director of E-Learning, Dr. Ravi Shankar, has been with us for decades. So, what were the golden words in 1922? You want to have a successful spinal anesthetic. You have to puncture the dura and arachnoid, enter into the subarachnoid space, and inject the agent. Local anesthetic drug. This is what is being told by Gaston Labat in 1922. See that it does not change much. When it is failed, what is the definition of failed anesthesia? Spinal. It is not effected within 10 minutes of a successful deposition of heavy or 25 minutes for plain. This is what we call as failed spinal anesthesia. It has not taken effect. It has not proceeded with the desired effect for 10 minutes if you bear hyperbaric, or 25 minutes if you give plain propionate or plain bupivacaine. This is what is called the definition of failed spinal. We have three options now. We are not able to enter the subarachnoid space. The drug has been injected at the right location, but the block is not as expected. The drug works very well, super, but we have not given the proper dosage. Now, there are certain clinical definitions. Okay? On the back, it is not acted at all. Acted but deficient in quantity, quality, or duration, whatever it is. Now, if you give spinal bupivacaine for cesarean section, and it has reached up to level T10, you are doubtful whether it is a bloody tap or not, and it recedes in 20 minutes, then it becomes a failed spinal. There are a lot of doubts about what is the incidence. Again, I am telling you, unless you know the definition, if the definition itself is changed, the incidence varies. Normally, it is 4% in many reviews. See, an anesthetic technique is very common. Spinal anesthesia, where the failure is very common, 4%. But still, there is not much debate about this topic. That's a problem. We are looking into so many things, but here, the commonest problem. See, of these 3.2 to 4%, 41% there is no block, and 59 it is insufficient block. So these are the problems. 3 to 4%, 41 is no sensory, and 59 is insufficient. Younger age, number of adults, no adjuvants. All these are independent risk factors for failure. If you know the incidence, see here, there is an incidence. Tetracaine with epinephrine, 30%, lignocaine, all very ACT, 3%. Again, the failure rate, I will put as 3 to 5%. If you can't go near it, it's also failed spinal. For example, it is a failed lumbar puncture. We are not getting the fluid only. Dry tap. I don't believe in this dry tap. You are in the subarachnoid space. You should get fluid if everything is okay. If you have some blood in the syringe or needle here, some blood is clogging, all these things may get you a dry tap. But this dry tap, I don't believe. If you are in the CSF, if your needle is okay, it should come out. The needle without the stillet, sometimes you put a stillet and going. Sometimes to adjust it, you do like this without the stillet. So where there may be some tissue clogging and you may not get. But these are not very common. Faulty position. I will be discussing the technical failed anesthesia in a different technical spinal anesthesia in a different video, but I'm going to tell you need to have flexion. There are a lot of people who do without much flexion with paramedian technique and all. But stick to basics. Tip of the table patient, flexion, shoulder straight, There is C, kyphosis, scoliosis, fracture, previous lamina surgery. Sometimes in obese patient, you may see a midline in sitting position, but sometimes the reverse may be true. The role of the assistant is very important. I will always say there are three important facilitators of good spinal anesthesia. Number one is the patient. He should be cooperative or he should be well sedated. Number two is the assistant. And number three is the anesthetist. So if the first two are good, the third one is very easy. This is what I always tell. See here, this is dislocation. Already patient has got operated here and he wants some other surgery like hemorrhoids or this side injury or something like that. Or he may have a scoliosis like this. Now we have got ultrasound and all to counter these problems. I want to tell this problem. This is L3 height. This is T5 low. Now, if you give the drug below this, it is likely to move down. So you cannot expect a level high when you give below L3 with the same volume. My concept, I'm telling you. And again, if you go like this and L2, 3 or L1, 2 somewhere here or thoracic spinal, it will flow. So if you are giving above L3, so the upward flow is better because the point of height is like this. You can get a female like this and male like this. Very important here. See here, the females are like this. The males are like this. This is a clinical point. A calm, relaxed patient is more likely to assume the correct position. So prepare and explain. Slow handling. A light anxiolytic pre-medication. I always give some good pre-medication like midazolam or some buprenorphine or some fentanyl, both fentanyl or in sometimes if you have phenergan in young patients, I used to give some phenergan also with fentanyl. Local anesthetic infiltration is very important. Sometimes if you give local, no, you will not feel where is the space. That it should not be there. It should be precise. Which space? Midline or hitting the bone. See, very important. The patient is little obese. And if you are hitting the bone within 2 centimeters or 1.5, it is likely to be spinous process. And if you are hitting little deep, it is likely to be lamina. All these things will be easily seen in ultrasound, but clinically, in an obese patient, if you are hitting superficially, it is spinous process. If you are hitting relatively deep, it is lamina. Then spinous process means you have to take out and go little down. Lamina means you have to obliquely align into the interlaminar space. Get the melt picture. If you have midline calcification, for example, midline is full of ligaments. Paramedian is muscle. So midline calcified ligaments are there. Sound is there. Take it out and go paramedian. So this is what is the spine intrathecal space, posterior epidural space, and this is the spinal space. There is a pseudo-successful lumbar puncture, getting the fluid, but the fluid is not CSF. Sometimes we are given epidural top-ups and just aspirate after the sweets. I'm telling you, usually what you do is you give an epidural and then combined spinal epidural, you use spinal. If you want to give the spinal after an epidural test dose, then you have to be thinking about this. So always give the spinal and then give the epidural test dose. Epidural top-ups, if you are sure or if you are doubtful, give the epidural top-up. See that everything is fine. Then you give the spinal. Arachnoid cyst may be there like this. You go inside the needle and then aspirate it and give it here. It will not act. Solution injection errors. Aspiration. Correct dose. Correct drug. Get the feel. CSF alone dripping is not sufficient. I will say this. Tuck, tuck, 2 gives. Now you have a mental feeling you are in this subarachnoid space. Then you remove the stylet. get the fluid. These two things are necessary. If you are not getting the feel when you are taking out and then fluid is coming and you inject, it is likely to fail. So get the feel and then CSF there and then give. Sometimes you go and hit the bone and then you remove the fillet, fluid will come. There you inject. It may not be sometimes successful. That is what is important. Get the feel, get the CSF and give the drug. Correct dose, specific local anesthetic, varicity, patient subsequent posture, a type of block intended, anticipation of duration of surgery, and the mass matters. Mass means how many milligram actually of bupivacaine. 15 milligram means of bupivacaine. Mass matters. I will say this is better. Lower lock. This is plain lower syringe. Now during the locking, the needle should be that much strictly in the space and position should not change. That should be your hand's integrity. Dexterity, what they call in spinal anesthesia. The dexterity of the fingers in handling the hub of the needle when you are tightening is exactly very important. That is what, when you just tighten it, sometimes aspiration may not come. It is slightly go inside. The give way have gone like that. So this is very important, especially in labor pain. See the back of the other hand. Aspirate, don't displace. Very important. You have to aspirate means everything is displaced. There are problems with pencil point needles. For example, you see here, this is fine. This is not very fine. You can see here, this is CSF is coming, but when you inject, sometimes goes into the epidural space, sometimes it is clogging here, sometimes it goes into the subdural space also. That is the problem. See, all these are possibilities in sometimes in pencil point needles. Very rarely there may be septa like this. So if you inject like here, and this will go and sit down like here inside. Okay. Now sometimes if you inject here, this septa will turn the fluid like, and this will settle here. Okay. That is the problem. So the volume may not have gone here, or volume may not have gone there. That depends upon your position. If you are given head low, then it may be settling here. Identification errors. Which drug is local? Which is test dose? Which is final? See, sometimes we have a clear formula. 5 ml syringe spinal, 2 ml syringe local, 10 ml syringe test dose. This should be the formula. 2 ml syringe local, 5 ml syringe bupivacaine heavy, and 10 ml syringe is the test dose. If you change it, it will be confusion like this. Here, so many ml syringes are there, which is the test dose, which is the local, and which is the spinal anesthetic will get confused. Chemical incompatibility, because there are so many things which are not studied. I have seen people using, I have myself used bupivacaine, midazolam, and ketamine in more than 300 cases. So LA with ketamine and midazolam, LA with adrenaline, LA with the two opioids. People use some buprogesic and some fentanyl. Clonidine with fentanyl with buprenorphine and with local. So all these things are possible, and we cannot be identifying whether it's failure or not, whether due to this incompatibility of these so many combinations. The ester type local anesthetics are chemically labile. So previously what happened was, now it is coming in sterile ampules. Previously the sensorkine and lignocaine ampules will be autoclaved before administering spinal anesthesia. So when this was a problem, the ester type local anesthetics are chemically labile. Heat sterilization, any chemical thing may not be good for ester local anesthetics. But newer amides are stable. There is something called scorpion sting resistance. I will not go into the detail of this sodium channel, but something it does. The scorpion sting does the sodium channel. So the sodium movement is somewhat restricted. So there is a mutation in the channel. So if there is a scorpion sting, what I do is I give history of scorpion sting. I give a little extra local anesthetic. Always add morphine or fentanyl. If you add a good dose of fentanyl, it will take care. See, many people in many hospitals say that this batch is not good. That batch is not good. I don't know whether it is bupivacaine batch or 2022 MBBS or MD batch. I don't know. But this batch is not good. That batch is not good. They'll tell. But chemical analysis have proved everything okay in all the cases. So the batch is not good is a big question. Now you have failed. Okay. You have not, you are given the spinal anesthetic. The level is T10 or T9 only. We want T6 or T8. Or sometimes we need T10, but the level is yellow. It is not at it at all. So this is what it is the present situation. Now what are we going to do? The level, a current pinch, the glance at the eyes, usually that you do know. Some pinch, yes, okay, surgeon will start. How many hours he'll be in head down? That is very difficult. The table and position are for the surgeons. Injected proper, but see here there are a lot of fibrous structures. There is something called Tarlov's cyst, where you take it out the fluid and inject here. That local anesthetic will be in the cyst. There are a lot of volume changes. Now you see the CS of dynamics is very important in the action of local anesthetics. Now in the lumbosacral region, one patient has got 80 ml of CSF. Another patient has got only 40 ml of CSF. What happens? This 3 ml of bupivacaine will act for T4 in one patient and T9 in another patient. So this is very difficult to identify in terms of how much volume of lumbosacral CSF is there. Don't blame yourself. I have not gone spinal. Sometimes this may be the reason for your inappropriate action or so-called of the local anesthetics. It may be a ballooned dural sac. Some pain fibers can pass via sympathetic nerves, and the sympathetic chain may be at a higher level. Now, you are handling the testis or some inguinal sac or something. Some of the fibers can travel via sympathetic and go to T4. Now your reach is only T8. Now that is why there's a big pain. Especially, I happen to, so many times I've experienced, in hernia, get a level of T4. Many times it is slightly painful. If you go at traction of either of the peritoneum, sometimes the fibers can be through sympathetics and get above your spinal level. Sometimes what happens is, if you go to a paramedian or lateral approach, the spinal nerve comes out. There is a dural investment, okay, in the lateral, just outside the interlaminar space, just outside. Then, if you prick, the CSF will come. And if you inject there, there is a lot of drug which be soaked by the nerve root, just exiting the canal. So there is problem of inadequate anesthesia. Rapid sequence anesthesia is more likely to fail. What is that? IV access monitors with staff 1. Some staff, another staff will paint, and the anesthetist will come and just give spinal. Don't touch, no local, nothing. No additives, larger dose. Start as the block starts. Be ready for GA. This is what is now. This is this non-stop rapid sequence fast spinal which was given by me because one staff has done the major work of IV fluids and monitors. The another staff has painted this and draped this with towel. Now I gave it the spinal non-touch within 40 seconds. This is what is called rapid sequence spinal, which I practiced many times in fetal distress. Management of failure, which we started with. Prevention is always better than cure. We prevent it. We see to that we see the we give the correct dose, we give the correct drug. So many confusions about syringes are not there. Yes, then prevention is best. Tincture of time 15 minutes, then you have to do for alternate arrangements. Wrong solution, wrong place, it is ineffective. Repeating the procedure, yes, we can repeat or convert to GA. When sometimes the patient has got itching, then you think that we have injected only morphine or only fentanyl. Good block, but less height. We can give head down. We can do this. Sometimes we obliterate this so-called kyphosis of the lumbar vertebra. So the drug moves above. This patchy blocks is used to describe a block that appears adequate in extent, but sensory and motor effects are incomplete. Some motor segments are bad. Quality is not good. So sometimes sedation, sometimes GA, sometimes you may need to inject locally. Always I say, when we repeat, we need to reduce this question. Now you are given the spinal anesthesia. The level is L1 for an appendectomy. When you give the block again, you always give again 3.2 ml with fentanyl, because if you give, because I have already given 3 ml, then L1 is blocked. And if you give only 1 ml now, what happens is L1, L2, L3 will get more intense block and the height will not rise. If you give the lower dose, already paralyzed, already blocked segments will get more intense block rather than fresh segments. This is the most important critical point. So that is why we need to inject the same dose, give again the same dose and wait. Anesthetized nerves are prone for injuries, so always be very careful, very smooth, especially when you are going the second time. Rescue measures and GA. Very important is because many times already existing sympathetic block and hypotension, because the level is T9, 10 or 11. We want an appendectomy T11, it is not possible. We are proceeding with GA. But as soon as you give proper fall, the BP will be 60-40. So whenever you are in a failed spinal, beware of GA starting, induction. Always document and explain the patients. Right place, right drug, and the right dose. These are the three musketeers in success. Now you decide, I'm going to give spinal anesthesia for this case. Now you do a lumbar puncture, give the local anesthetic drug, let it spread, and there is an action on nerves. Now what are the problems? Failure can happen in any of the 4 areas. The first thing is abnormalities of the thigh. Ligamentum flavum may be thick. A flexible small needle. Position is not good. Anesthetist is not good. Scoliosis, kyphosis, already operated. So many things are there. Lumbar puncture is failure. Leaks, partly outside. That is what I told about pencil point. Wrong drugs. We have done the lumbar puncture, but we are injecting somewhere else. We are injecting into this somewhere else. Yes, local injection is done. Where is the space? How much is the CSF volume, 40 ml or 80 ml? What are the anatomical changes? And what is the position now? All these things matters. Okay. Spread, bloody taps, high CSF pH, repeated autoclaving, resistance, age, drug volume, and which drugs. All these matters. The spread is not good. I have already told there may be septum, there may be fibrous sheath. So the pH of CSF may be high. All these things matters when you are going to give the drug. So this is the basic idea of failed spinal anesthesia approach. Barker wrote, for successful, it is necessary to enter the dural sac effectually with the point of the needle, discharge through this all the contemplated dose of the drug directly and freely into the CSF below the termination of the cord. This is what he has told long back. Feel and give. That's my message now. You have to feel and get the CSF and then give. So preoperatively noted, intraoperatively noted, assess, assure, sedate, Drugs which increase position, valsalva, cough, epidural volume extension. This we can do. When you think that the level is T10, you already also have an epidural space. You can inject epidurally, either normal saline, volume extension. Just when you see the ultrasound, if you give the drug epidurally or caudally, you can see the compression of the dura and the spread of the CSF. You can very clearly see this ultrasound. Then you can go for general anesthesia. Assess, assure, local, sedate, and GA. Repeat dose, drug important. So thank you very much. Slides are at painfreepartha.com and YouTube is painfreepartha.